Okay, so to start off, let's introduce our mentors from UCSF. Joining us today is Dr. John Sumoski. He's the Associate Professor of Medicine and Division of HIV in UCSF. And with us today is also Dr. Emma Bainbridge, who's the Assistant Clinical Professor, also from the Division of HIV at UCSF. So let's begin.
And so thanks, John and Emma, for joining us today. I will be presenting a case that was shared with us by one of our participants, Dr. Marion Quinn. So this is a case of a 29-year-old male diagnosed with clinical stage 4 HIV in 2018. So when our doctor saw the patient, he was just discharged from another facility where he was admitted for pneumonia. The baseline CD4 count of this patient was 65 cells per cubic millimeters. And he was actually started on 3TC TDF efavirenz, and was taking this with good compliance. He was also started on cotrimoxazole prophylaxis, but then he developed generalized rash, and so the cotrimoxazole had to be discontinued. During that period, he was also diagnosed to have pulmonary tuberculosis, and he was treated with anti-TB meds for 6 months. Viral suppression was achieved 8 months from initiation of antiretroviral treatment. The patient, however, was lost to follow-up and did not come back for ARV refills for 1 year. In 2020, he was admitted for GI tuberculosis, and this was bacteriologically confirmed. TB treatment was initiated, and his ART with the same combination, 3TC TDF efavirenz, was resumed. Viral load 1 month from restarting antiretroviral treatment showed that it was very high. It was 89,200 copies per mil. The patient was then assessed to have treatment failure. Genotyping was done, and the results were as follows. So there were mutations, the following mutations: K65R, M184I, K101E, Y181C, and G190A, and K103M. The ART regimen was revised to 3TC ACT plus boosted lopinavir. Since TB treatment was still ongoing, the dose of lopinavir-ritonavir was doubled. Patient was, however, not compliant with treatment, was again lost to follow-up despite several attempts to contact him. The patient was readmitted 5 months ago due to severe PCP. And due to previous history of hypersensitive to cotrimoxazole, PCP was treated with clindamycin and primaquine. The patient claimed that he completed TB treatment in another facility. At that time, sputum expert MTB-RIF was negative. So the standard doses of 3TC ACT plus lopinavir-ritonavir was restarted 2 weeks after initiation of PCP treatment. Patient has been very compliant with these medications, but a month ago, there was an AZT stock out, and he was shifted to 3TC TDF dolutegravir plus lopinavir-ritonavir. And he is now due for repeat viral load after 1 month. So I will now turn over the discussion to our experts. So Emma, you can share your slides. Thank you.